Hello and welcome. Today we're going to talk about the stroke program here in the Baptist Health System. The hospital requires 2 hours of stroke education per year, and this includes all physicians that care for stroke patients, including hospitalists and intensive care doctors, and of course emergency physicians as well. All Baptist Hospital System hospitals are certified primary stroke centers, means that they can give TPA acutely for ischemic strokes up to 4.5 hours. St. Luke's Baptist is our comprehensive stroke center, which has an interventional lab with neurointerventionalists on call 24 hours a day for anterior and posterior large vessel occlusive strokes. And we'll get into how to access this a little later. The Hospital Medical Executive Board has mandated that the order sets be used for all stroke patients across the continuum of care from the emergency department to discharge. These are also called power plans. We have to use the BHS, that's the Baptist Health System stroke orders, not the Tenet orders. And I'm going to show you how to figure out the difference between these. All patients that present with stroke will have to have a dysphagia screen documented prior to any oral intake. Obviously, if the patient fails the dysphagia screen, they should not have any PO intake. The key thing on this is that some TIA patients may appear perfectly normal, but a couple of days later that they may have an MRI that shows a small lacunar infarct. Well, if they had PO intake prior to a dysphagia screen, this metric will be a fallout. All patients who get TPA in the emergency department should have it done within the first 60 minutes of arrival. This is especially true of those who last known well was within 2 hours. The goal for this is 95%. The acceptable reasons are available in CPOE, and I'll show you in a minute how to access that. Please note that an acceptable reason is not by a delay in the teleneurologist. This is not an acceptable reason. So how do you document acceptable delays in TPA beyond the 60-minute mark? Well, with the patient's name highlighted in the tracking shell, click on the ad hoc button above, and then once that's selected, you'll see alteplase inclusion, exclusion criteria, treatment delay. And if you click on this, it will have the acceptable reasons you can document. For patients that are stroke alert patients, that's patients that have last known well within 6 hours of presentation and stroke symptoms, an NIH stroke scale has to be documented within 15 minutes of arrival by the physician. If they are not a stroke alert patient, that is, if their symptoms are last known well is greater than 6 hours, the NIH stroke scale can be done by the nurse anytime during the emergency department visit. But again, less than 6 hours from last known well, the emergency physician needs to document an NIH stroke scale within the first 15 minutes. Now, we should be documenting last known well, not onset. Onset is ambiguous. When the abstractors look through the chart, they will look for last known well. The place we document this, again, is with the ad hoc button. So you select the patient, then from the tracking shell, click on the ad hoc button. You then select last known well from the list of options. You then document the last known well if it is known. Baptist also has contracted with teleneurologists to remotely evaluate patients to aid us in taking care of them. The particular teleneurologist is specialist on call. They can consult on any neurologic patient, but particularly for patients that are having strokes. A key element is they do not write orders. The ED physician must write orders for the TPA if it's indicated. Also, the delays by SOC in seeing the patient are not acceptable reasons for delay in TPA. They may also alert us to patients that may be neurointerventional candidates that are not specifically recognized by the NIH stroke scale of 6 or the VAN positivity. So how do we access SOC? Well, when the stroke alert's called, the nurses will automatically set up the equipment in the room. The ED physician for emergent cases will fill out a consult form online. There's a icon on the desk that we'll click to open up the form to fill out. Now, we do not have to use SOC in evaluating our patients. Specifically, you do not have to have SOC's consent or consultation to give TPA or begin the neurointervention alert. And here's a copy of what their online form looks like to fill out for a consultation. Now, we spoke earlier about the BHS stroke order sets or power plans that are mandated by MEBUs. Now I'm going to show you how to access these. This will be the same process that we use for all mandated order sets such as sepsis and sedation and of course stroke. So on the order screen you will select the shared section. So you see mine, public, and shared. Do not use the public, go to shared. Do not click on the public. This will bring up the Tenet nationwide standards, which are not specific for our hospital system. So do not use the public ones for stroke or any of the ones where we track metrics such as sepsis or sedation. Once you've clicked on shared, begin to type BHS or Baptist Health System, and then when you see emergency medicine come up, click on emergency medicine. Within the emergency medicine one, you click on favorites, and you'll see in this the BHS ED stroke ischemic with TPA alteplase with a number after it, and BHS ED stroke alert evaluation with a number after it. Now to save these to your favorites folder, you'll need to actually begin the order on this. So you'll see this BHS ED stroke alert evaluation. You'll need to go ahead and open the order. You don't save it yet. Saving it now will just save it to this individual patient. Once you have the order open, you can check the things that you always want done and then go to Save as My Favorite at the bottom of the order form. When you begin to save it, this will come up. It'll have the name of it with the number. You have one more step. You put your name in front of the order just as it is. Don't modify the rest of it, because our usage of the standard order sets or power plan are tracked, and if you modify it, it can't be tracked and it'll be assumed that you're not using them. Alternatively, you can search for the order set each time instead of placing it in your favorites, but it's easier to save it to your favorites. So we talked earlier about the NIH stroke scale, which we have to do within 15 minutes for all stroke alerts. Well, you find this in the procedure section. In the NIH stroke scale, again, has to be timed within the first 15 minutes of arrival. Generally, we're doing this as soon as we see the patient, but the documentation of it has to be within the first 15 minutes for stroke alerts. Now we come to one last important aspect of Activase or TPA ordering in Cerner. Again, we have to use the BHS TPA order, which is in the stroke power plan with TPA. We select the alteplase, which has the order for 0.9 milligrams per kilogram IV once. Once you start to place this order, this screen will come up. This is a very busy screen, but the only thing that you need to look for really is the final dose. If the patient is 100 kilograms or more, the final dose would be 90 milligrams or 0.9 milligrams, which is the maximum dose for TPA in stroke. If the patient is less than 100 kilograms, it will calculate it automatically, and you can just click at the bottom right hand corner, apply dose. Cerner does not have two separate orders for the bolus and the infusion. It has the nurse calculate the bolus and infusion under the comments tab, which we'll look at in a minute. So just look for that final max dose. It can't be above 90. The instructions the nurses have for administering TPA, look at the bottom by clicking the caret on the left that points down to a straight arrow, and then click on Order Comments. This spells out for the nurse exactly how to give the dose, specifically the bolus and then the infusion. One more reminder, we have to write for the Activase or TPA orders. The specialists on call, the teleneurologists, do not write for this. So this is the end of our discussion of stroke and Baptist. I hope it's helpful. If you have any questions, please feel free to ask me or ask any of the ED medical directors, and I appreciate your time. So what do we do with patients that have non-traumatic intracranial hemorrhage? Well, most of these patients will end up staying at the hospital where they present and not being transferred to St. Luke's Baptist. But what we should do is contact the neurosurgeon on call via Access Baptist to have them evaluate the CT and discuss with us the patient's findings. If they determine that the patient has a neurosurgical problem, they will accept them and they'll be transferred to St. Luke's Baptist. Just as a note for our stroke center performance measures, our target blood pressure for intracranial hemorrhages should be less than 140 systolic. So how about if these patients that have intracranial hemorrhages are on Coumadin or one of the new novel anticoagulants such as 10A or direct thrombin inhibitors? Well, we have reversal orders that are being developed for these patients. Currently, there's a paper order set which I have developed into my favorites order set. There are Kcentra, or the prothrombin complex orders for patients who are on Coumadin with varying levels of INRs. Then there's also an order for the Kcentra for the 10A or the direct thrombin inhibitors. Additionally, the Baptist Health System has Praxibine for those patients that are on Pradaxa. Additionally, the St. Luke's takes care of aneurysmal subarachnoid hemorrhage. One of the metrics we have for that is to maintain the systolic blood pressure less than 160. So you'll notice this is different than intracranial hemorrhage, which is 140. And to be given nimodipine within 24 hours and continued every 4 hours for 24 hours. Acceptable reasons for not giving nimodipine are allergy to nimodipine or hypotension. This completes our discussion of stroke in the Baptist Health System. If you have any questions, please let me know or let your department directors know. Thank you.